Good. Good morning, everyone. I'm Suman Rao, and for me, I think all are familiar, all are new faces, and I'm looking forward to make new friends. And that also could be one of the reasons could be that this topic is also maybe something a little new to you all. So I'm glad to be the opening speaker of today and take you through kangaroo mother care, the new guidelines that have come out by the World Health Organization, and also the evidence behind it. I bring greetings from my institute, St. John's Medical College, Bangalore, and from the Department of MCA, the World Health Organization, where I work as a consultant. So the first question is, and I haven't made it a poll, but I would like to ask a question of how many of you all practice kangaroo mother care in your neonatal units with a show of hands, please. Oh, that's fantastic. So then I retract my words of bringing something new. I'm just bringing new evidence to you all. And when we look at the global burden of low birth weights, it's huge. It's 15% of all births in the world, but they contribute to a whopping 80% of neonatal deaths. And that's why in the world, we are focusing on kangaroo mother care. Not only from mortality point of view, but it also, we know that low birth weight contributes to a lot for morbidity and neurodevelopmental delays. And one important intervention we have is kangaroo mother care, which we know is not only skin to skin care, it is continuous, prolonged skin to skin care with exclusive breastfeeding. And over the past 40 years, we have enough evidence that it is a big game changer for the low birth weight. It can reduce mortality by a huge 40%, and almost all the morbidities can be reduced by kangaroo mother care, whether it's hypothermia, hypoglycemia, it promotes growth, and it also reduces um, readmissions in the first year. Since 2002, WHO has always had a strong recommendation for low birth weight infants. In fact, every manual on newborns which come out does talk about kangaroo mother care. In the 2015 recommendations, what we saw was that kangaroo mother care was recommended for the low birth weight babies less than 2,000 grams to be started only in facilities and to be started only once the baby was stable. And the word stable was something that we all grappled with. What is stable? And therefore, in reality, kangaroo mother care practice was not very high. In 2015, it was less than 5% of all low birth weights in the world were getting KMC. And one of the reasons was that it was started only in hospitals. And we know, especially in LMIC, a number of births happen at home. And the big group of babies who needed it, the very sick ones, were not getting it. And therefore, in 2015, WHO came out with 3 research programs to look at how we can address it. How can we quickly scale up kangaroo care to reach to all the babies? And that was the Scale Up KMC study. The second one was, can we do kangaroo mother care for babies who are born at home? That is the community-initiated KMC study. And the third one, which is the newest in the series, is, can we do it for the babies who are unstable? Does it have an effect? And that's the immediate KMC study. And I'm going to take you through all 3. So this I call as the trilogy of KMC research, which has changed practice. And the first one in that was about implementation research. This was almost a decade ago, where implementation research was a new science. And we who were doing this work were all sort of grappling with how to go about it. And here in this implementation research, what was different from other research is that we had our outcome at hand. We were told that at the end of 2 years, you have to get all low birth weight baby kangaroo mother care to 80% of the babies should be getting it. And then there were 2 more layers of complexity. It was not any KMC. You have to get at least 8 hours per day of kangaroo mother care. And This is for all babies born in a population of about 2 million. So it was a population-based study. So we in the room who were going to start the study, we said impossible. We were trying to bargain with them and say, let's get it down to 2 hours of KMC, 4 hours of KMC. But the WHO team was very, very clear. It should be minimum 8 hours of kangaroo mother care. And even the aspirational goal was 80%. So we started off with this, and I was one of the PIs in one of the sites. And this was done in 4 sites in Ethiopia and 3 sites in India. The first thing we wanted to understand were the barriers for kangaroo mother care. So let me now ask you all, what do you think are the barriers to kangaroo mother care? Do you think it is the families, it's the mothers who find it difficult, the families, the health personnel? What is it? Hmm, okay, very interesting. Excellent. I think we can move forward, and we had a lot of answers that the culture doesn't allow it. The religion may not allow them to expose. The mothers and families are not ready. But I'm glad that you are looking at the system and also the health personnel. For us, what we found was exactly this. Not so much nurses, but we found doctors and nurses were the biggest barriers. We found it so difficult to give the responsibility to the family. And like you all have shown here, mothers and fathers not comfortable were way down the list, not at all there. But we also had other problems. The first one, which was easily fixable, was that we couldn't identify low birth weight babies well in the community. We used to use the scales with the needle, and there was lot of rounding and heaping around 2,500 grams. In fact, if you had a baby who was 2,500 grams, one third of those babies were actually low birth weight. So we were missing a lot of denominator, the group. And this was easily fixed by just replacing all the weighing machines by the digital weighing scales across the district. The second one, the big challenge was doctors and nurses. They were not looking at kangaroo care as an alternative. They thought that NICU care is preferable, incubator care is preferable. And of course, as you said, initiation of KMC was late and therefore missed out on a lot of babies. And in these LMICs, babies are discharged early, and therefore we had this challenge of continuing kangaroo mother care in the community, and the facility community linkage was something we had to work with. So we worked pre-facility to get these babies to the facility because that is where kangaroo mother care was practiced. At that point, the recommendation was still start KMC in the facility. We identified babies with the help of digital weighing scales. A lot of work had to be done in motivating the health personnel in the facility to support kangaroo mother care. And then we established community facility linkages, and we did a lot of work in the community to promote kangaroo mother care as a something that the family would ask for when they come to the facility if they had a low birth weight baby. So we used a lot of meetings, religious meetings, other things to promote it. And we always found that the family, the fathers were very, very supportive. And we managed to get to where we wanted. So both in all the sites in Ethiopia and in India, we managed to have a KMC initiation of ranging from 63 to 89, and in India it was 84 to 92%. And this was in a small period of just 2 years, working in an entire population. But do remember, our goal was quality KMC with 8 hours of KMC and exclusive breastfeeding. With that, we reached somewhere around 50 to 62% in the Indian sites and a little higher in the Ethiopian side. So we did manage to bring about it. And this is something which is going into the KMC implementation guidance to say how communities can scale up kangaroo mother care rapidly. This was published around 3 years ago in the BMJ Global Health. The second one, which was a single center study, was a randomized control trial to look at what is the benefit if you start kangaroo mother care in the community, either for those babies who were born there at home or those babies who came back in the first 3 days from facilities without having initiated KMC. And this was a very large trial done in Haryana in India with more than 8,400 babies. And here, the main outcome was a hardcore outcome of neonatal mortality, but we also had exclusive breastfeeding and care seeking for hospitalization in the first year. This one had a huge number of participants, and this was not only for babies who were less than 2,000, but it also included babies who were slightly bigger than this. And this study showed that it's possible to do kangaroo mother care of good quality. And look at the time here, it was almost 11 hours of kangaroo mother care was the norm in the community. And with this, they found that kangaroo mother care reduced mortality in babies who were initiated in KMC in the community by 30%. But it also showed us one important thing, that even in babies who are between 2 and 2.5 kgs, it has a big benefit. Even in them, the mortality reduction was almost 40%. And this has a big implication on our recommendations later. The third one was the immediate kangaroo mother care study. And in this study, this was again an individual randomized control trial. Probably among the three, this was the one which has got the maximum enthusiasm across the globe, I think. Because this was about doing kangaroo mother care where we are comfortable with, the neonatologists and the nurses, that is in our NICUs. And here we looked at starting kangaroo mother care for babies who were still not stable immediately after birth. And this study was done in 5 countries, 4 in Africa and 1 in Asia, that is India. And the group that we were looking at were the very small babies between 1 to 1.8 kg. And the intervention was to start kangaroo mother care as soon as possible after birth, within the first 2 hours, and give prolonged KMC aspiring to more than 20 hours per day, along with exclusive breastfeeding, and try to not to separate the baby and the mother for anything, not even for procedures, as much as possible. And this was a challenge even to us who were hardcore KMC, I would say, fanatics. 20 hours per day was till now mainly seen in South America and Colombia. All of us who were doing it were struggling to do 8 to 10 hours of kangaroo mother care. For this, there was a big need to change the design of the NICU and make it a mother newborn ICU, where the mother would come in immediately after birth. And our goal was to ask for the vaginally delivered mothers and those who delivered by C-section by around 6 hours. And therefore, we had now 2 patients in the ICU, both the mother and the baby. And here, all the procedures for a sick baby had to be done in kangaroo care. Respiratory support, most of the centers had only CPAP, and they provided that in KMC. And for us, the big surprise from the study, that with committed health personnel, it was possible to do, even in these sick babies in the ICU, the average duration of KMC in the intervention arm was 17 hours per day. And with this was compared with the conventional care where KMC was started, but it was started only after the baby was getting stable, initially sitting next to the babies in the ICU, and then they were moved to the KMC ward. In the KMC ward, where KMC was given to stable babies, both of them received almost 19 to 20 hours per day, so there was no difference there. And the big surprise for us was that it had a huge impact on mortality. In fact, this was one study which was stopped midway because the DSMB felt it's unethical to continue because the data was staring in the face. So it was stopped only when half the recruitment was done, because already there was a reduction in mortality by 25%. And in some outcomes like hypothermia and suspect sepsis. Sepsis is important because especially in the LMIC, the health personnel were concerned about allowing the mother in, thinking it would increase infection. So in fact, it was the latter, it reduced infection. And this was published in NEJM in 2021, the immediate KMC study. Now it's been 3 years since this paper is out, and I would like to ask you all, I think the poll would come a little later, but we would take that later. But these 3 studies, once we had done with this, WHO had the task of trying to make this into a new recommendation. So immediately after these studies were all published, WHO convened the guideline development group to look at all aspects of low birth weight care. And one of the big things in that was kangaroo mother care, which came into the preventive and promotive care strategy. And the new strong recommendation was that It was already there. KMC was recommended for low birth weight babies, but now it was for all preterm and all low birth weight babies, not just less than 2 kgs. It could be for babies started in the facility or at home. And then there was an important quality component that it's not as long as possible. It is still as long as possible, but a minimum of 8 hours per day. So this is the big change in the recommendation. And then there was a new recommendation on immediate KMC to be started as soon as possible after birth for all preterm or low birth weight babies without waiting for stabilization. Both are strong recommendations. And for this, just these 3 studies were not enough. We had to do a new meta-analysis and a new review, and therefore it was commissioned to a group in India, and they asked 2 questions. One is, how is KMC different from conventional care? What is the effect? And they looked at population, setting, and daily duration of KMC. And the second one was early initiated KMC versus late initiation without waiting for stabilization. This new meta-analysis is also published in BMJ Global Health. And here, like any other recommendation that we come out in WHO, the outcomes have to be hardcore, not things like duration of hospitalization, duration of ventilation, but hardcore outcomes, particularly mortality, sepsis, growth. These were the main outcomes that we were looking at. So the evidence there were more than 31 studies, 27 of them focusing on KMC and conventional care, and only 4 focusing on early initiation. And as you would expect, because you all already know that the Cochrane meta-analysis had shown a huge reduction, KMC definitely reduces mortality. There was a 32% reduction in mortality by discharge or 28 days. But when we looked at babies, all babies less than 2.5 kgs, and did a subgroup analysis, and this is very important from public health point of view, it also results in a 38% reduction in mortality in low birth weight babies between 2 and 2.5 kg. Now, why is this of importance? Because almost 4/5 of our low birth weight babies are in this category. So if we are going to give kangaroo mother care for all low birth weight babies, we have to make a big change in our postnatal wards, the way we look at all these babies. So this has major public health importance. Gestational age at birth, we looked at all babies and even babies who were preterm, but more than 34 weeks, the late preterm, there was also a big benefit. And this is important, again, where you start the community-initiated KMC. I know in a lot of LMICs, there has been a move to a great extent, especially in my country, for institutional deliveries. But even for those babies who miss out on this in the hospital or who deliver at home, kangaroo mother care can be and should be started in the community. So there again, it brings about a reduction in mortality. Now, this slide is important to tell us that it is when you give KMC for prolonged periods, and we had 9 studies in that group and 4 studies in very prolonged duration, compared to 9 studies where they gave less than 8 hours, the mortality reduction was mainly when the duration of KMC was more than 8 hours. And that is why now the KMC recommendation is do it as long as possible, yes, but a minimum is 8 hours. And I'm sure all of you all are practicing in your units. This is a big challenge, and we have to move towards it. The longer, the greater was the reduction in mortality. So this now showed us that it is beneficial in all gestational age less than 37 weeks, in all low birth weights, both in the community and the facility, and we should give it for at least 8 hours. And this, therefore, was, especially for mortality, it was a high certainty evidence, and all the other things, there was also benefit, and thereby by that, the recommendation has changed, and it's a big change. When we look at the other question of when to start, we had less number of studies, and the big study in this was the IKMC study. And when we looked at this, we again found that mortality is reduced by, in addition to conventional KMC. Please mind here that the control group is conventional KMC, mortality reduction is there, and therefore we need to start KMC as soon as possible after birth. These were the other outcomes, and we found a benefit for sepsis, exclusive breastfeeding at discharge, and also for hypothermia. So again, because of the high certainty of evidence and decrease in mortality, we have a new recommendation of starting kangaroo mother care early. Now, this is almost 3 years, and I would like to know how many of you all, when do you start kangaroo mother care? Has your practice changed? Are you still waiting for stability? And this is a question which sometimes when we pose to a larger audience, they fail to differentiate between skin to skin contact at birth and KMC. Skin to skin contact at birth, like if you look at the data from India, from our SNCUs, we find every baby seems to be getting KMC because they mistake skin to skin contact at birth. We are not talking about that. We're talking about continuous prolonged KMC even beyond the first hour and giving for prolonged periods. And here you see here, yes, a lot of us are still waiting for stability. It is a challenge. In my own unit, I find it a little challenging to start. I can start KMC early. We have managed to do it through a quality improvement program, but giving it for prolonged periods like 17 to 18 hours, we have to change our ICU. Unless the mother's bed is brought in to give prolonged periods of kangaroo mother care, it is not possible. And here, another important piece of information I need to give you is that it's not only with the mother that we achieved it, it was with the surrogate. So, right in the beginning, we may need to enroll the surrogate like a family member to do it. And in the IKMC study, it was a female family member for logistic purposes. I know we got a lot of backlash from the community saying, why didn't you involve fathers? You're most welcome to involve fathers and partners, but we need to start kangaroo mother care as early as possible. So, with this, the guideline development group said, yes, we need to make this strong recommendation, and the benefits are large. And therefore, we have these two new strong recommendations. So, here again, I would like to highlight that the study was done only for babies who were on CPAP and non invasive support. It did not include babies who are mechanically ventilated, and therefore, there is a word there that in healthcare facilities, if the baby is unable to breathe spontaneously after resuscitation, is in shock or needs mechanical ventilation, these guidelines do not apply for them. Having said that, I find it easier to do it for mechanically ventilated babies than babies on CPAP. It's so much more secure. The only reason this thing is here is because the study did not include them. So nothing to stop you all from doing it for mechanically ventilated babies. But the important thing is here, you must monitor them. Just because we're giving the babies to the mother doesn't mean that they don't need monitoring. We need monitoring, maybe more intensive, because we need to ensure that the baby is getting all the treatment the baby gets. Only the place has changed. It's no longer the womb or the incubator, but it's the mother's chest. So, what is the potential impact of these three WHO studies? Now, the first one, the current impact of KMC with 5% coverage, with 40% reduction in mortality, was around 10,000 deaths prevented per year. Now, on that, if you add the scale up KMC study and you reach 80% of the population, then it is going to increase to 150,000. But if you do the other two studies that you start for all babies in the community and you start for sick babies, then it's a whopping 400,000 babies deaths are going to be prevented per year. So this is a big public health importance. And therefore, the WHO has the stage which sort of guides the WHO to look at how to bring about impact on the newborns. Has the stage group has convened the kangaroo mother care working group to look at how we can make this change rapidly globally. And this KMC working group has all the stakeholders who are interested in the mother and newborn. And with this, they have come out with three main outputs. The first output, which is already out there, is the global position paper, which talks about kangaroo mother care as the center of a transformation around which the entire care for low birth weight babies is designed. And this is for both LMIC and high income countries. It's for all babies in the world. So this global position paper is already out. It also talks about the implementation strategy of how countries should go about promoting kangaroo mother care. These two are already out. The third one, which we are waiting for, which is getting finalized, is a revision of the practice guide which came out in 2000, I think, 2. It's been 2 decades now, on how at the ground, how nurses and doctors and other health personnel can practice kangaroo mother care. In addition, like you saw from your poll, three-fourths of us are still waiting for stability. So this change by just a guideline is not going to make that big change. So now WHO is looking at implementation research, how to bridge this knowledge do gap over a short period. And this implementation research is happening in 4 countries. And here we are not only looking at developing a model of how to scale up immediate KMC very rapidly, but also to see is effectiveness in the real world by doing a cluster RCT to see what is the big change it's going to make. So this has started. We are in the first phase of where we are in the developing the model. In addition, nothing which is monitored is going to evolve. Evaluation is, we know, king. And therefore, there has been a big work going on to make kangaroo mother care as one of the ENAP indicators. And this is in the making, like all countries have to report on how many babies got kangaroo mother care, proportion of low birth weight babies initiated in kangaroo care. We tried looking at putting quality KMC, but was finding it difficult. So currently the ENAP indicator would just be how many of the low birth weight babies got kangaroo mother care. So this is a story of how WHO in 2014 identified gaps, research gaps, and we found that there were 3 major research gaps, and it took up studies to bridge these gaps. And those were the scale-up KMC, community KMC, and the IKMC studies. With this, it came out with the WHO recommendations, and then it was all about implementation, the stage working group, giving global recommendations, implementation research to see how to make it possible, dissemination with the countries, and monitoring. And this brings out to a full cycle. And I'm sure the cycle will again show us research gaps, and the cycle would continue. Thank you very much for your patient hearing, and very glad to take any questions.